All right, we're back at Sensible 2020. Our next panel is From the Festivals to the Streets, Psychedelic Harm Reduction and Community Mental Health. Your moderator is Vilmarie Narloch. Vilmarie.
Thank you, Seth. Yes, so I do have a slideshow here that I'm gonna, so yes, thank you all so much for being here. This session is going to be myself, Irina Alexander, and Allie Wilens. I will let them introduce themselves quickly here before we get started. Irina, why don't you go first?
Hi, my name's Irina, and I am a therapist at the Harm Reduction Therapy Center. I'm also an adherence rater with MAPS for the MDMA therapy studies. I also have been a supervisor for the Zendo project and done a bunch of other things with SSDP and other drug policy organizations. So anyway, Vilmarie and I have done this talk a few times just over the past few years, but we've done a version of it that was just about psychedelic harm reduction, and now we're taking that and applying it to mental health crises on the street. So I'm also here with
Allie.
Hi, I'm Allie Wilens. I'm very inspired by these two women up here. I am a New York State EMT and a harm reductionist. I have also do a lot of work in the community organizing around non-police response to mental health crisis calls, integrating a lot of what we learned from psychedelic peer support.
Thank you. And I guess I can share that I am the director of drug education for Students for Sensible Drug Policy. I also run a psychedelic harm reduction integration group here in Chicago and have a certificate in psychedelic assisted therapies and research. So I have a lot of interest in this field, so to speak, and also how it applies to sort of general and community mental health, which is why this topic is so important to me. So let's get back to the slideshow here.
I actually, this is kind of important. I'm also a psychedelic therapist. I forgot about that. That's kind of important for this. So I do ketamine therapy at Sage Institute in Oakland, where we have a sliding scale psychedelic therapy clinic.
Great, thank you. Okay, so overall for this session, we're talking about, again, applying the principles of psychedelic harm reduction to community mental health. So it's about learning how to engage with someone that's experiencing a crisis and when it may be best not to engage, so understanding some boundaries around that. We'll be talking about some alternatives to calling 911 in order to sort of protect everyone involved, and also learning how to connect people to some resources that they might need. So first, Irina, if you could talk a little bit about some of the types of crises. And then I know, Allie, you also wanted to add something to this as well.
Yeah, so I've been doing street-based outreach work, counseling and therapy for the past 10 years. And in doing that work, there are so many different types of crises that I've seen and that just kind of unfold in life, but it's a little harder on the streets. Some of them being just emotional dysregulation, unmet basic needs, so like food, water, shelter, harm to self, harm to others, suicidal ideation, homicidal ideation, and auditory and visual hallucinations, paranoia, just being like really afraid that something bad is going to be happening, and then overdose and other medical emergencies, which Allie will talk more about.
Yes, and so this is a point that I would love for us all to internalize, because a lot of times we think about responding to mental health crisis as it's a purely mental phenomenon, but a lot of the times there are physical and medical reasons why somebody could be having a difficult experience. And I'll give an example of that at a later point in the talk, but just to keep that in mind for now.
Thank you, thank you. Okay, so one of the first things that you do is kind of assess the situation and consider various boundaries here. So that's sort of what this is all about. So you want to consider people's privacy and not wanting to intrude. You want to consider sort of reflect on yourself and your own sort of capacity, whether your presence is helping or hurting the situation, and whether you have the capacity to support. Irina, could you sort of expand on a couple of these to give folks kind of a an example or some background as to what that assessment might look like?
Yeah, I think just one thing that I wanted to add in here is that assessing, like with the privacy in mind, keep in mind that when people are living on the streets, when you're walking up to them, you're literally just walking straight into their living room or into their bedroom, you know, and they don't know you, you're a stranger. So there is like a little bit of just like pausing and making sure that it's an appropriate space to walk into and getting the consent to walk in there, that you have to do before you just kind of like jump in and, you know, get into this role of like, I'm the hero and I'm going to rescue someone. So really pause first and reflect on all these things.
Yeah, and in addition to that, things that can go into that, things like language competency, understanding, you know, like, are you the best person? Who could you call if you're not? And this is something that we think about on the personal level. Am I a good person to connect with this person? Do I have capacity to interact with this person? Can I hold this container safely? And then if not, also understanding on the municipal level, would that be a good choice for this person at this time? Or is there something else present in the environment or circumstance that would make even those resources not appropriate?
Mm-hmm. Yeah, and just a little bit extra on this self-reflection piece. Part of it is kind of considering how you might be perceived by that person, by the person experiencing the crisis. So you want to consider, you know, perhaps if they're experiencing a lot of paranoia, they might see you as a real threat. And so that's just something to consider and kind of think about when you're wondering whether your presence is helping or hurting and whether you are the right person to be supporting that person. Okay, so now we're going to go into a few of the different sort of principles of psychedelic harm reduction with a twist as it applies to community mental health.
So
go ahead. Yeah.
The first one, so we're taking the Zendo principles and then actually just like making them shift a little bit to fit this. So the first Zendo principle is create a safe space. But we're talking about creating a safe-ish space when you're out on the streets, because it's actually a lot of times impossible to create a safe space for folks who are living outside. There can be violence, there can be a lot of just unsafe scenarios, like being without a home. And one of the first things that you can do to help create a safe-ish space is help people just get their basic needs met. Like sometimes not having water, not having food is a really big problem out on the streets. And that's one way to really just help someone like create a container of safety, as opposed to being at a festival where there actually is that safe container. So looking at people's basic needs. Also, sometimes it's just not possible to create safety, and using empathy as a tool is in and of itself creating at least like relational safety. You know, people are like being seen and witnessed and heard and valued, and that in and of itself is a way to create some sort of safe-ish space. And obviously, if it's unsafe for you to engage, then don't. This is not the type of situation where you should be like throwing yourself in and no matter what happens to me, it doesn't matter. Like that's where the whole martyrdom complex comes in, and that's not what we're telling you to do. If it's not safe, then don't go in.
Yeah, and piggybacking off of that in terms of communication with somebody who's in an altered state, in terms of safety to the provider and safety to that person, a lot of times there's a disrespect for, I guess, nonsense talk. A lot of times you'll approach somebody and they're not communicating in a way that feels rational to us. And if we are impatient, we might write off what that person is saying instead of considering that as useful information. So what I think is really important is to kind of approach with a respect for what's going on with that person and put them at ease, and understand that they may be giving you important information about what's happening with them. So for instance, they're relative to the food, Irina brought up food and physical needs. I wanted to bring up the example of somebody who is insulin dependent, who people see inject himself with insulin at a bar, who later gets confused, clumsy, starts acting combative, so they call 911. When EMS arrives, the bartender says they saw him shooting up and they thought that it was heroin. the pupils aren't constricted. You don't see, it doesn't seem like the person is on heroin. The patient could be yelling that they, you know, like, did you bring the donuts, or something like very like unusual that you wouldn't be expecting somebody to say. You know, like, what are you talking about? Everyone assumes the patient is high, but the patient isn't high. This is a real example of somebody who actually had diabetes and was mistaken for an injection drug user, who had been injecting himself with insulin, and then his blood sugar fell low, and that caused him to present in this particular way. And if people had ignored him, it's possible he could have had a seizure. He was asking for donuts because his blood sugar was low. He needed administration of oral glucose, and he didn't know how to communicate that any other way. So I think, you know, this is illustrative of the fact that the stigma of people who use drugs impairs response for people in altered states regardless of cause. And so this is, you know, common ground for developing allies and how we change these policies. And also just illustrating that sometimes you need to take care of a physical need, and that starts by considering your patient the primary source of information on what's going on with them, even if they're in an altered state and are communicating in an unusual way. Mm-hmm. And if you respect them too and are approaching in that manner, it will make you safer as a provider. A lot of people go in and they disrespect what patients are saying, and they try to come to assert some kind of dominance, and that can be really dangerous, because that's when people are most threatened and will react the most aggressively.
Mm-hmm. And you miss some valuable information, right? That empathy required for you to recognize that the person saying donut is like having, you know, some sort of diabetic crisis. You know, I think that's a huge thing. So thank you for that example. Okay, we'll move on to our second one here, which according to Zendo is sitting, not guiding. And for our purposes, we're talking about sitting versus directing. So there are some cases where in a crisis, sort of just sitting with the person and being empathic and you know, providing that sort of container can be really useful. And there are some situations that may be a lot more emergent, where you might need to do a little bit more directing. So identifying whether it's an emergency and taking the steps a little bit more, you know, to protect, you know, everyone involved, right? So if someone's asking you to call 911, that would be a good point in which to do so. If there's a medical emergency, of course, right? And there's important sort of things to consider when making that kind of call. And Allie, as our sort of like resident medical kind of person, can you share a little bit about what sorts of things people might want to keep in mind if they do get to a point where they need to call 911?
Yes. So, well, first of all, would you like me to talk here about why some people do not want to call 911, or should we bring that up later? Sure. Okay. Well, so one thing to consider is that whether it's because of domestic violence, immigration status, drug use, other illegal activity, or fear of police, there are a lot of people who are afraid to call 911. And for some people, that is a valid concern. It is good to know about the Good Samaritan policies in your area, just like there are Good Samaritan policies on campuses. There are Good Samaritan policies in cities and other municipalities that can protect you if you call 911 and there's illegal activity being found on site. Another great thing to know is that EMS are not mandatory reporters for most things. It's a gray area in terms of domestic violence. We do have to report child abuse, but we don't have to report really anything else that might be going on with you. So that's a broad array of circumstances in which you may be afraid to call, and we are not going to say anything about what's going on there. Another reason people are afraid to call is that they maybe have some bad associations with inpatient treatment for enforced treatment. A lot of times it's true if you're in an altered state and you do call 911, you will be, you know, if you are unable to decline being transported and yourself, and it seems like could be something life-threatening going on with you, there's something called implied consent, which means that you will probably be taken to the hospital regardless of whether or not you want to in that moment. And that could be, you know, an upsetting circumstance. So you might have something worked out with your friends in advance, like, hey, if something like this were to happen and and you're absolutely sure that you don't need to call 911, like maybe I don't want to go, but you got to be aware that that there could be some consequences to doing that, because a lot of times there is a medical reason. And before I touch on what some of those are, I want to also mention that jails are currently the largest mental health provider in the country. So there are a lot of people who, through their encounters with first responders, when police are sent on those calls as well, they get, it's their contact with the criminal justice system that could have longer ranging effects, whether they're on a substance or not. If you're presenting in an altered way, earlier I made the example of the person with diabetes. The American Diabetes Association actually has an entire guidance for lawyers on what to do if somebody with diabetes has been sent to jail or arrested as a result of a presentation from their diabetes, because it has happened so often. So this is a real consideration in terms of of whether or not when you should call. A difficulty breathing, if you have any kind of if you suspect in any way that their airway might be compromised by what's happening, it's really important to call, because we're talking about life threats here. If you suspect a life threat, you know, and when you're waiting for them to 911 to arrive, you can keep somebody in the recovery position that's on your side, so that if they do, you know, have something that they want to throw up, it wouldn't block their airway for them to do so. Being aware, there are other questions that you can ask, but I just want to list a couple of things here. Head trauma, hypothermia, nutritional deficiencies, seizures, heart attack, low blood sugar, low oxygen. These are all different things. And also taking a substance on which somebody has overdosed. These are all medical reasons why somebody could be presenting with altered mental status. And when it comes to substance use, which is of particular interest to this audience, it's important to be aware that somebody could be talking to you, you know, being in an altered state, and the metabolism of the drug could be such that they have yet to overdose. They're not currently, you know, there isn't an immediate life threat from their overdose, but over the course of an hour or two, perhaps that changes and they actually are in a situation now where they could be overdosing in a fatal manner. And so it's important, like if you are going to take the commitment to be watching somebody, that you're regularly checking on them and checking their vital signs. And honestly, most people don't have the capacity to manage that kind of program themselves without training. So if you have a friend and, like, you know, they've got blue lips, like there's anything that suggests that they're not able to manage their own airway or get adequate airflow, you should call 911.
Thank you for that. I kind of want to also shift to the opposite side of that, or the other side of that, in the sort of the more non-directional support, because there may be situations where maybe someone is in a crisis or in a place of need, but isn't going to need all of that intervention. And Irina, you had a really good example of someone that you worked with that you were able to sort of have a lot of like patience and empathy with. It kind of worked out pretty well. Can you talk about that a little?
Yeah, I mean, this comes up a lot. Like, I think the bottom line is that we don't know people, we don't know their traumas, we don't know what they need. And, you know, just walking in on someone and saying like, oh, your life, I know what you need, it doesn't work. And in fact, like that lacks that empathy that you were talking about earlier. An example that comes to mind is a client of mine who just every time we would go on outreach, she would be like, you know what, like, I don't need anything. I'm not homeless. Like, it's cool. But then she would just sit on the same part of the street every single night. And, you know, to us, like, communicate that she wasn't homeless and didn't need anything. So we kept just staying consistent. And after a while, you know, I would be like, oh, I know you don't need anything, but we just have some snacks at the end of the night. And with that consistency, and instead of like pushing her and being like, no, I know you're homeless, I know that you have needs, I know what they are, we were able to really slowly develop a relationship. And eventually she made some sort of comment about how her immune system wasn't the best. And shortly after that, I found out that there was housing available for folks who were HIV positive. And turns out, like, really just like gently put it out there, and after, a few months, we ended up developing a relationship, and she did say that she was HIV positive and ended up getting housing and then getting treatment and living to this day. So yeah, that's just one example that comes to mind, but really like staying present, letting the person take the lead on where the conversation is going, not trying to like push them in one direction or another unless it is one of these like kind of more dangerous scenarios. And I did want to add too, if you do call 911 and it is an overdose, then not mentioning drugs over the phone is usually a good idea, because then oftentimes I'll send cops ahead of people who actually should be there. So just something else to keep in mind.
Mm-hmm, mm-hmm. And the next principle, according to Zendo, is talking through, not talking down. And we've adapted this to be talking to, not talking down. And I think we take that to mean that talking to people as like humans. And, in a crisis situation, sometimes, like we've said, people might be presenting in ways that maybe you're not used to, or they might be talking about things that seem a little bizarre or paranoid or kind of wacky. So, oftentimes what we see people try to do is like, oh, that's not true. Or like, you don't really see that. That thing isn't there. The thing that you're seeing, I don't see that there. So really sort of like, dismissing that person's experience. And what we're talking about is essentially, it's not your job to bring that person into like your own reality. You're not going to stop the hallucinations. Their reality is real to them. And so it's not really useful to question that, particularly in a sort of crisis moment. And so instead you're thinking about, you want to be exploring with them sort of like what the feelings are that they're having about whatever is going on in their context. Are they agitated? Are they sad? Are they annoyed? And working with that instead of whether or not what they're talking about is real. So things like paying attention to things like body language, speed of communication, the complexity of the conversation, those are more some strategies to be considering. And I had a client who I worked with a few years ago who had a psychotic condition and had a lot of sort of bizarre experiences that were a real challenge to her. And she had family that wasn't very supportive, and that would do a lot of like, that isn't real kind of stuff. And so oftentimes what that ended up looking like as far as supporting her was responding to her multiple phone calls throughout the day. So she would call just really as sort of like a grounding check for herself. Her biggest concern was that the sun was dying. And so a lot of what I did is sort of talk to her about what that meant and like what she felt about that and what her fears were about that. So really talking about like realistically what she was experiencing emotionally as she was, experiencing this concern of the sun dying. And oftentimes it just took, 5 minutes on the phone of us just kind of talking through her feelings about it. And then she would be like, okay. So it's really almost just like a grounding exercise that you might do if you're checking in with a friend. It had sort of the similar outcome in that she was able to calm down, just kind of talking through her feelings about it. So then the next one.
I think, just to add really quickly there too, I think that in our society, unfortunately, this kind of view of like psychosis is that like, oh, your brain is broken, something bad is happening. But in a lot of other cultures, something like, what you were just describing, Bill, would be seen totally differently. And people, I try to look at it as like people have access to just like different states of consciousness and different awareness of, things that like I don't necessarily have access to. And sometimes it comes out in like really beautiful metaphor or story or like visuals or audio. And just because it's not something that I understand, from my own personal experience, doesn't mean that it's not like just as valid and just as real as my kind of like consensual reality. So yeah, just keeping that in mind too, I think is important.
Yeah, that curiosity and
thank
that
you.
is so important because you can't, you might not, you know, there's this idea of like, oh, caregiving versus caretaking. The difference is who is it for? So like, are we trying to make someone's behavior palatable to us because it makes us uncomfortable? Is that our immediate goal? Or is our goal to like find out what the source of their agitation might be and to provide support for that? And so like, there might be circumstances in which I might, you know, offer my perspective as a different, as like in contradiction to what they're saying, but maybe only if they were saying things like, I feel like people are chasing me. Like, do you feel like people are chasing me? You know, like if they directly ask me that, I might say, you know, like, I might affirm that like in their present situation, like we don't see anybody out there. We're going to keep good watch, you know, like we're making sure if there are people out there, you know, like we're going to notice, and like we'll let you know, like you can relax, like you know, like you can assure a person and like and enter in your perspective into that, but in a way that doesn't say like, no one's chasing you, don't worry about it, you're being crazy. like you know what I mean? Like there's a lot in between there.
Yeah, that's a good point. And the client I mentioned as my example, she would sometimes ask me, do you think the sun is dying? Like, what do you, like, she would ask me what my thoughts were on it. And all I could really say is like, I haven't heard anything about that. I haven't seen any news about that or any research about that. And sometimes that was enough to help her feel more calm too, is, you know, she would ask. I would never offer that information, but sometimes she would ask, and then I would be able to sort of share what my experience was with that thing that she was dealing with.
Yeah, and so often like we really don't know, you know, like so often like there might actually be someone like following, there might be like an FBI agent following one of our clients, and like I have no idea at the end of the day, you know. So yeah, like all we can really do is be there with the person. And a lot of times it's actually like from a psychological perspective, really, it can be potentially dangerous to get rid of someone's so-called delusions, you know, because they're like brains are really smart, and a lot of times they can develop these defenses to keep the psyche safe. And if you break down a defense and tear it down, first off, most of the time, if you try to do that, it'll just get stronger. But if a person actually gets to the point where their like delusional protective mechanism does break, then that can be really potentially scary for them and unsafe.
Thank you for those insights, both of you. So the next principle is difficult is not the same as bad. And we have adapted it to be difficult doesn't always have to be bad. And so what we're kind of thinking about here is, you know, the concept of like having a bad trip, right? When it comes to psychedelics. Well, sometimes people have, you know, difficult experiences in using other drugs. And a lot of that has to do with sort of like our social context and the drug war being very harmful and debilitating to a lot of people who use drugs. And so it can often come back to, you know, it's one thing to help someone through a difficult trip at a festival, right? At a music festival. It's a whole lot different to be doing that on the day-to-day and sort of a more community-based setting. You know, and stigma plays a big role in this as well. I have a person who lived in my neighborhood who would take walks all over the neighborhood and was often talking to themselves, often like almost combatively talking to themselves. And people really viewed this person as an angry, mean person. And they were sort of concerned for their safety. And I would see sort of like threads on some of the worst places on the internet, which is like the neighborhood Facebook pages, about this like horrible, mean person walking around our neighborhood. And as people were sort of like sharing more information and a description of the person, I realized that this is the same person that I walk by, you know, when I get off the train from work, who is like sitting at the corner talking to themselves, smoking a cigarette. And the difference in my experience is because when I saw that person, I would say hi, and they would always stop their other conversation and look at me and say hi. So I never saw this person as you know, a danger to the neighborhood. I didn't see them as having like this really challenging, mental health crisis, they were kind of just going about their day. But stigma, I think we've kind of noted that already in this session, that, people can often place a lot of negative viewpoints on people, and that can be more harmful than whatever it is that they're experiencing in their head or as a result of using a substance. So I'm wondering if either of you two have any other thoughts about how this particular principle applies to what we do in the community.
Yeah, I think one thing that just comes to mind right off the bat as we're talking about stigma is how many of my clients have insights that are very similar to insights people have while on acid or other, more on psychedelics that they have while they're using speed. And I just have so many conversations with clients who are like, I saw God for the first time. I was able to connect with myself on a different level. I was able to really truly understand, get enough energy to start to understand what my goals in life are and what my purpose is in life. And the other day I had a client who had taken acid come in and reflect on what a positive support speed had been for him in his life, which had been filled with a lot of trauma and homelessness. And he was like, wow, speed really kept me safe through a lot of times. And also reflecting on his relationship with it and being like, and I don't know what my relationship with it in the future is going to look like, but I'm so grateful for the role that it's played in my life. There's just so much, they're just psychedelic elitism of these drugs are okay and these drugs aren't, because these drugs get you to think and reflect, and then these drugs just keep you safe at times and help you live, and also can help you think and reflect. It's, that whole thing is really weird.
Thank you for that. Yeah, I think that's really important. So I'm recognizing our time, so I want to get to our last couple of slides here. So all of that said, all of that great information that we just shared, it's really important for us to recognize our own boundaries. So this goes back to understanding what our capacity is, right? So you can't really help others if you aren't in a grounded place yourself. So that's always something to do sort of like a mental check about. And another thing to check, of course, is your privilege. A lot of people want to do a lot of things to help, but you want to recognize sort of the white savior complex, sort of martyrdom, and if you're just helping out of guilt, and whether that is more for you than it is for the other person. There's a broad spectrum of boundaries that you can set, so it's important to know yourself and look out for burnout. We all have our own sort of signs for ourselves of what burnout looks like. So it's important to sort of reflect on that, and there's lots of different ways to look into that. The trauma stewardship that Irina added on here is a really good resource. And I'm wondering if there's anything else quickly that either of you would add to this boundaries piece.
Don't hit on somebody if you're holding space for them in a difficult psychedelic experience. That seems like an obvious point, but it isn't for many people that I have met.
Excellent. Thank you for that. That is a very good boundary.
I think there's also another panel at the conference that's about boundaries, right?
Awesome. I think there's supposed to be, I'm not sure if it is still in this last version of the conference, so we'll see. Okay. And then
that extends to mental health crisis in general. There's actually like a whole thing of people who are experiencing like the fetishization of people who have mental illness. Like we don't need to go too much deep into it, but this is a real thing that people prey on this. Like people will go to support groups and will will frequent them and pick up multiple people who go to those support groups. This is just to be mindful that if you're in a place yourself where you're prioritizing your own healing, or you're having a hard time, to be aware. It's people shouldn't feel like they can't pursue love, and people shouldn't feel like they can't do peer support or be useful or help others if they're having, a prolonged state of crisis or illness themselves. But we really need to be aware of how we can hurt ourselves and other people, and just be extra mindful.
Yeah, thank you for that. And so lastly, these are just a few sort of next steps that you can think about as far as figuring out ways that you can help in your community. So first and foremost is researching what sort of crisis services exist, so that if there is some other option to where you don't have to call 911 first, maybe there is a mental health sort of team that has their own resources, that has their own sort of number that you would call first. Knowing where to get things like naloxone and other harm reduction supplies in your area. Taking CPR, first aid classes. Mental health first aid is another great resource that can get you some more of this kind of information. And most importantly is get to know your neighbors. Like I mentioned, those Facebook and like Nextdoor groups are kind of like the worst. So get to know your neighbors if you can in person. And I know Allie had some stuff to talk about with regard to like developing a community support system, but I think that might be a good piece to add to the Q&A so other folks can also sort of share what other things they have going on, and because we're limited in time.
Okay,
So,
I would like to say like one thing about that real quick, if that's all right.
Sure, very quickly.
Okay, so very quickly, I just want to put out this concept of social determinants of health, and understanding that there's like a lot of that there may be things that are helpful to a person for their mental illness, that other beyond just the holding space, the capacity for treatment. So like things like supportive housing, access to healthcare, flexible employment, seeing those as early stage mental health interventions, in addition to how we can actually reform our crisis response systems so that they are more harm reduction oriented.
Thank you. And so lastly, we just had a couple of questions that we were going to ask the audience if we were going to be doing this in a live format. So I'm just going to throw these up here really quickly, maybe give you a couple of things to think about as we get into the Q&A. So the first thing is, we recognize that some people might hesitate to engage in someone experiencing a crisis. And we were just kind of curious what those reasons were, why you might have hesitated to engage with someone experiencing a crisis. And if you've witnessed a crisis situation when you didn't know what to do, we were just kind of curious about people's experiences with that. And with that, we will leave you and get to the Q&A.